brolucizumab injection. 22 days after receiving topical and oral steroids, we noticed resolving vasculitis but with still persistent disc edema. FFA showing disc hyperfluorescence 6 weeks after. This is the disc edema even persistent after 70 days. So the diagnosis of brolucizumab-induced peripheral vasculitis with disc edema was made. Rest all other investigations for the uveitis came out to be within normal limit. So now comes to the discussion. Brolucizumab is the latest FDA-approved anti-VEGF agent that was shown to be non-inferior to aflibercept in visual acuity outcomes in the pivotal Hawk and Harrier trials. In phase 3 clinical trials of brolucizumab for NAMD, ocular inflammation was reported to be higher in the brolucizumab group as compared to the other aflibercepts and the ranibizumab group. So what is basically the mechanism of action of brolucizumab? It is a humanized single-chain antibody fragment that inhibits almost all the forms of VEGF-A. Basically, its small molecular weight, high molar doses, and its high drug concentration allow its remarkable effect, which is almost 11 times of the dose of aflibercept and 22 times the dose of the ranibizumab. Its mechanism of action of vasculitis, basically how it causes vasculitis, is due to the presence of pre-treatment anti-drug antibody found to be 35 to 52% in the treatment-naive patients. This is contrast very high as compared to the other groups. It is basically type 3 deposits which play a significant role of AD in these reactions. It can also be hypothesized that with the combination of its high dose and the diseases such as the diabetes, which is basically the weak blood retinal barrier, allow its effect more and causes the chances of vasculitis more in the diabetic patient as compared to the patients who have non-diabetic and only has neovascular age-related macular degeneration. This is from one of the articles showing intra-article gray deposits resolved on its own. This is another one which resolved on the topical steroids. So now the question arises whether there are increased chance of vasculitis after multiple injection. Basically, retinal arterial occlusion with severe vision loss, possibly secondary to the inflammatory responses, can occur after subsequent intravitreal brolucizumab injection, even if no inflammation occurred after the initial first dose. This is another article. This patient, in the top row patient, received the intravitreal bevacizumab. No reaction occurred, but same patient received intravitreal brolucizumab in his left eye, and we can see the intra-arterial grayish deposit 21 days after the injection. So now the question arises how we can diagnose this disease. With a complete thorough fundoscopy examination, wide field FFA, so we can detect the hyperfluorescence, staining of the vessel walls. Basically, clinicians are encouraged to use wide field imaging only with peripheral sweeps for a quantitative examination of the entire retina to detect any inflammation, leakage or ischemia. Treatment, it is important to detect early type 4 hypersensitivity reactions because these can occur even up to after 6 weeks. FFA changes can be seen even after 8 weeks of the injection. Basically, this condition resolves with the help of topical and the oral steroids, but in few cases, it can be required intravitreal corticosteroids, triamcinolone acetate, and other corticosteroid implants. So, whether to repeat brolucizumab, right now, Novartis recommends withholding additional brolucizumab if intraocular inflammation has occurred after use. So, the conclusion that a case of retinal artery peripheral vasculitis after multiple injections of the brolucizumab for IPCV. Fortunately, early diagnosis and treatment after disease onset prevented its severe visual impairment. Thank you.
Very nice presentation, Dr. Prisha.
Thank you.
So, what was the final outcome of your patient? Like after 70 days itself, still the vasculitis did not resolve completely?
No, sir. Vasculitis resolved. Only there was a persistent disc edema, but it also resolved eventually, only with the help of topical as well as oral steroids.
Achha, so you needed both the things to resolve. And during this time, what was the state of the visual acuity of the patient?
So there was not much visual acuity affected because she was already in case of IPC. Her vision was never 6/6. Vision remains almost stable. But she came to us with the complaint of fluctus. She has received many injections in the past, but she never complained. But this time, with a different molecule, even she received past 2 brolucizumab also, there was no complaint. But this time she came to us with the complaint of fluctus. She said, this time I am not feeling exactly before because she has received many injections. So this time she was a bit uncomfortable. So then we did the investigations and in the very periphery only vasculitis was there.
So if there is a peripheral vasculitis, incidental finding,
yes, sir.
No vision decrease, will you treat?
Yes, sir.
Okay. So in all cases you are doing optos? What is the recommendation after intravitreal? What do you do?
No,
How
sir.
do you follow?
Usually we are not doing in every patient of octo, but in this case we already know that the brolucizumab there is already a chances of high chances, so we were already worried. And she complained of floaters, so we did the fundoscopic examination and then we did the octos.
Which cases you have given this drug? These cases were resistance to Eylea.
Yes, sir. These were she was not improving markedly as compared. So we tried another molecule, shifting.
Shifting of the
Yes, sir.
Okay. Anyone would like to? Thank you. Good.
Thank you, Abhishek.
Thank you. Thank you.
I am present clinical case presentation of phototoxic maculopathy. Phototoxic maculopathy can cause irreversible vision loss by exposure to UV rays of 400 to 440 nanometer, as shorter wavelength of visible light are readily absorbed by cornea and lens. There is predisposition of toxicity to occur in younger patients due to better clarity of clear ocular media. The mechanism of phototoxicity has been inferred from prior studies based on solar or other types of photic diseases or damages including laser-induced maculopathy. The outer retina is particularly vulnerable to photic damage by photochemical damage potentially mediated by free radicals. The 25-year-old male presented with a complaint of diminution of vision for 6 months and distortion of image for 3 months. He is welder by occupation. Uncorrected visual acuity was 618 in both the eyes, and best corrected was 6.9 with correction of 0.5 spherical and 0.5 cylindrical at 90 degrees, and in left eye 6.9. NCT was normal. Extraocular movement was full in all cases. Reactions were normal. On Amsler grid, metamorphosia is present in both the eyes. On fundus examination, it was normal. On OCT, it shows disruption of submacular retinal layer. Patient was made diagnosed.
Go back. Photo.
Just one slide back in.
What is the finding?
Sir, disruption of submacular retinal layer.
ठीक है, next.
So, patient was diagnosed with bilateral phototoxic maculopathy and was advised to wear dark glasses, which prevents that shorter wavelength which is affecting his eyes. Discussion previously identified this factor has been included intensity of light source, proximity to retinal surface and length of exposure. In the era of indocyanine green assisted ILM peeling, the use of ICG and the technique of ILM peeling may both contribute to subsequent phototoxic maculopathy. Phototoxic maculopathy can cause endoillumination during macular surgery is uncommon. Conclusion. I have described the case of 25-year-old male who was welder by occupation, presented with diminution of vision, metamorphosia and OCT thinning of retinal layer. It was suspected with maculopathy of result of photic injury. The patient was in this patient the phototoxic maculopathy due to photothermal and photomechanical damage is likely due to welding.
Okay. Metamorphosia is tested by which method?
So by Amsler grid.
Amsler grid. Okay. Which OCT you have used?
Sir, macular.
No, which OCT? Spectral domain or time domain?
What was your OCT?
OCT.
SDOCT?
Sir, SDO. Oh,
SDOCT.
SDO.
Thank you.
Our next speaker.
Good morning, everyone.
Presentation. Going here.
everyone. I'm Dr. Mehak Mandla and I'll be presenting on Turson syndrome. We had a patient aged 34 years old, male, a resident of Firozpur and farmer by occupation. The chief complaints of the patient were diminution of vision in both eyes, which was gradual, progressive and painless in nature. History of present illness. The patient presented with gradual progressive loss of vision, which severely impaired his routine activities and grossly impacted the quality of life. Past history. The patient a year ago was found unconscious in his room with Glasgow Coma scale of 8, experiencing seizure. He also experienced acute respiratory failure and was developing hydrocephalus. On hospital admission, a computed tomography scan was done and angiography was done, which revealed an aneurysm in middle cerebral artery. Ultrasound Doppler was done, which revealed a thrombus in great Sepnus vein. And so he went terminal of internal carotid artery, along with insertion of external ventricular drain, which was finally removed after 15 days. He was extubated with a Glasgow Coma scale of 14. The patient was diagnosed with subarachnoid hemorrhage. Once the patient was stable and regained consciousness, he complained of bilateral loss of vision, making him dependent on his relatives. Personal and family history was not significant. Ocular examination. The best corrected visual acuity of the patient in both eyes was hand movement positive. The perception of light and projection of rays were accurate. The intraocular pressure as measured by Goldman application tonometry was 16 and 19 in both eyes. Extraocular movements were full, free and painless in all cases, and no nystagmus was seen. The lids and adnexa were normal, conjunctiva was normal, cornea was clear, anterior chamber was quiet and well formed. Iris had normal color and pattern. Both the pupils were normal in shape and reaction. The lighter plexus were normal without any relative afferent pupillary defect. The lens were phakic in both eyes. When we did fundus examination, it revealed dense vitreous hemorrhage. Management. Initial investigations were done, which revealed a normal blood profile and viral markers. B-scan was done, which revealed bilateral vitreous hemorrhage with an attached retina. The patient had subarachnoid hemorrhage and bilateral dense vitreous hemorrhage. A diagnosis of Turson's was made. On account of young age and bilateral dense vitreous hemorrhage and extreme deterioration in quality of life, a 23-gauge pars plana vitrectomy was planned. So here we were doing the pars plana vitrectomy. Initially right eye was done, followed by left eye 2 weeks later. Post-operative findings after 5 months. The best corrected visual acuity of the patient improved to 6.9, which with pinhole it improved to 6.6. The intraocular pressure as measured by Goldman application tonometry was 17 and 15. Extraocular movements were full and free and painless in all cases without any nystagmus. Lids and adnexa were normal, conjunctiva was normal with cornea was clear in both eyes, anterior chamber was quiet and well formed. Iris had normal color and pattern. The pupil had normal shape and reaction with normal light reflexes and no relative afferent pupillary defect. The lens were phakic. The fundus photograph taken 5 months post-op revealed clearing of the vitreous hemorrhage. OCT was done, which showed mild diffuse edema with internal limiting folds. Discussion. Turson syndrome is a rare intraocular hemorrhage which is mostly associated with subarachnoid hemorrhage and can be seen post any brain injury. It is hypothesized that whenever there is a sudden increase in intracranial pressure, it would lead to retinal vessels rupture. The bilateral incidence is around 42 to 87.5% and occurs around 8 to 19% cases with subarachnoid hemorrhage. Screening is crucial in all the patients of subarachnoid hemorrhage and particularly those with low Glasgow Coma scale. Fundus examination is the gold standard. Management. We do a 23-gauge pars plana. Initial 3-month period of observation is done with 23-gauge pars plana vitrectomy. We can also do intravitreal injections of tissue plasminogens. Complications include proliferative vitreoretinopathy, glaucoma, epiretinal membrane formation. Factors affecting prognosis include the age, rate of pre- and post-operative complications, and neurological conditions of the patient. Thank you.
Thank you. I think it's quite straightforward with things that it's going on. But my only thing is that in the management one is that obviously in this case you would probably have to wait for some time because of the neurological deficit or the neurological clearance.
Yes, sir. So the patient first he had to manage the neurological symptoms,
Yeah,
only
so-
post after he came
Otherwise,
out.
I don't think that it's standard practice now to really wait for so long.
Yes, sir.
Secondly, what is the role of tissue plasminogen activator?
So it helps in clearing of the breaking of the clots and clearing of the hemorrhage, early clearing of the hemorrhage.
But you are not used, eh? This is
No, sir,
written
so
in
we
literature.
yes, sir,
ठीक है.
yes.
ठीक है.
Okay, thank
It's
you.
quite
Thank you.
expensive for the patient to do.
So next we have, thank you. So next we have Dr. Neetu, and she's going to be speaking on an unsolved puzzle. Dr. Ranjita.
Dr. Ranjita.
Yeah, so a case of 32 years old male with sympathetic ophthalmia.
Good morning, everyone. Today I am going to present a case on sympathetic ophthalmitis. So, 32 years old male presented at the IOPD with complaint of the gradual diminution of vision without as watering but associated with the fever. And the diminution of vision was complained by the patient was on the right eye. And the coming to the history of past illness, he had a history of left eye iron hook injury 4 months back, after which the primary repair under the GA and AC was done for the open groove injury. He had no history of hypertension, diabetes, thyroid disease or sickle cell disease. Coming to the general physical examination, the patient was conscious, oriented to time, place and person. There was no pallor, icterus or clubbing. And coming to the systemic examination, his CVS, CNS and chest examination were within normal limit. Coming to the ocular examination, on the right eye, his visual acuity was hand movement positive, and the left eye it was PL absent. And the intraocular pressure was 11 millimeter mercury in the right eye, and left eye couldn't be recorded. And his cornea was clear in the right eye, but due to the complete corneal opacity in the left eye, the other findings like anterior chamber findings, iris, pupil and lens couldn't be assessed in the left eye, but in the right eye it was within normal limit. As we can see in the right eye, the cornea is clear, and pupil is circular and reacting to the light. And in the left eye, as due to the iron hook injury, there was a primary repair, as we can see the sutures present. Coming to the next examination, as you can see in the right eye, the B scan shows a choroidal thickening. And when we did the OCT of the OCT examination of the right eye, there was subretinal fluid present in the right eye, that is the affected eye. And then we did the fundus examination. There were multifocal choroidal infiltrates present. Then we did a fundus fluorescent angiography in the right eye. As we can see in the venous space, there were multiple leaking foci present. As we can see in the fourth and fifth pictures, there are multiple leaking foci are present. Then we did blood examination, which were within normal limit. Then, as we thought of it might be a sympathetic ophthalmitis, so we started the management, medical management with injection methylprednisolone 500 mg 1 vial IVBD with 1 unit DNS, and injection cefosolvactam 1 gram IVBD, then injection pantoprazole, eye drop difluprednate and eye drop humide. Then, as we can see, after the 4 days of treatment, there is a regression of the symptom. Then, after day 4, we continued the treatment with injection methylprednisolone, cefosolvactam, and pantoprazole, and other eye drops were continued, but injection methylcobalamin was added. Then, as we can see, after the day 10, the subretinal fluid that was present on the day of presentation was regressed massively. Then, after day 10, we continued the medication with injection methylprednisolone, injection methylcobalamin, and then we added tab amoxicillin and clavulanic acid, and tab prednisolone 40 milligram 1 tab OD, and then pantoprazole, and other eye drops were continued. So coming to my take-home message, the eyes being small and delicate structures, sometimes even apparently minor trauma can have devastating effects. Though rare, the disease is potentially sight-threatening. Prompt recognition with early institution of steroid therapy helps to salvage the vision. Frequent OCT imaging of both eyes is important. The careful OCT evaluation may expedite the early treatment when indicated. Thank you.
Thank you. The diagnosis is basically based on what? Clinical or the investigation?
Both
Which is the
clinical and
clinically, what was your diagnosis? It was a
sir, as there was a history of
clear-cut diagnosis.
simple
Symptomatic. What else you could think of? Presentation wise. Why you added antibiotic?
So initially we're not sure
Of
is it sympathetic ophthalmitis
Or endophthalmitis?
yes.
How?
Endophthalmitis.
Endophthalmitis. So treatment is only steroid or anything else can be also be tried?
Sir, immunosuppressive can be given.
Okay, thank you.
I'd like to call Dr. Kastub Iriwadkar. Not there. So, Nawajish, Dr. Nawajish, is he here? Sorry.
So, good morning everyone. I'll be presenting an unusual case of macular hole in a young male. Normally when we talk about macular holes, we usually suspect them to be idiopathic, so they'll be more commonly seen in the 6th and 7th decades. Whereas when we talk about the younger age groups, the most common cause usually is trauma. So this case was a slightly move over.
Slide.
Okay, so this was a 30-year-old male who was the first issue of a non-consanguineous marriage who presented with gradually progressive diminution of vision for the past 1 year in his left eye. Unfortunately, he had history of trauma to his right eye 8 years back with a firecracker injury, and in his past history, he had a history of night blindness and was using high-powered glasses for the past 15 years. His systemic and family a corneal scar extending from the 12 to the 5 o'clock position. A USD B scan was done. It was suggestive of a disorganized globe structure, suggestive of phthisis bulbi. In the left eye, his vision was finger counting close to face with intraocular pressures within normal limits. His anterior segment was within normal limits, whereas on a dilated fundus examination, we could see areas of chorioretinal atrophy in the periphery with scalloped margins and a posterior pole retinal detachment combined with a macular hole and a fixed retinal fold in the inferotemporal quadrant. We went ahead and inquired about the glasses that he was using. So it was minus 22 diopter sphere in his left eye, and his axial length for that eye was 30.91 in the presence of a posterior pole retinal detachment. So this is the image that was there. You can see the red circles highlight the areas of chorioretinal atrophy with the scalloping of the margins almost involving the posterior pole, and there's presence of a full thickness macula of a macular hole. A diagnosis of gyrate atrophy with high attachment associated with macular hole was made. We went ahead and did serum ferritin levels, which was 824 micromoles per liter. Normal values are moles per liter. We did an ERG. There was an extinguished response in the ERG. Now we were in a dilemma. ERG extinguished response could be due to the gyrate atrophy as well as due to retinal detachment. We discussed this with the patient, and because he was one-eyed or monocular, we went ahead and offered a 25 gauge pars plana vitrectomy with ILM peeling with inverted ILM flap, which was done under explained visual prognosis. We did a 25 gauge pars plana vitrectomy, following a core vitrectomy, a triamcinolone acetonide assisted posterior vitreous detachment was done. It was extended to the periphery as much as possible. Then an ILM staining was done with BVG 0.05%, followed by release of the membranes at the posterior pole. At this point, iatrogenic breaks were formed because the membrane was tightly adherent. No problem. Myopic patient, we removed the PFCL, went ahead with membrane peeling as well as ILM peeling and an inverted ILM flap. We went ahead and did a fluid air exchange, and at this point we utilized the iatrogenic break as a posterior retinotomy, and an endolaser was applied to the break. Following which, standard post-operative treatment was advised, including an arginine-restricted diet and vitamin B6 supplementation that is most commonly done for gyrate atrophy. On post-operative day 7, we had used an intraocular tamponade with SF6, so you can see 50% filled with gas and multiple sections of the OCT showing that the hole had closed. However, there was poor gain of visual acuity. So we know that gyrate atrophy is autosomal recessive caused due to mutation in the OAT gene, which causes accumulation of ornithine, which is a toxic byproduct. Causes of macular hole in this patient, we went ahead and did a literature review. We found out that there are multiple macular involvements that have been reported in the past, but there is only a single case in which a full thickness macular hole has been reported. However, ours was different in terms of having a longer axial length, having a posterior pole retinal detachment associated with it, as well as a good anatomical outcome, even if the functional outcome was not great. So in our case, we dealt with a triple dilemma of myopia associated with a macular hole and a posterior pole retinal detachment in the setting of gyrate atrophy. 25 gauge vitrectomy helps, but early diagnosis is key so that arginine restricted diet is instituted at the earliest. Thank you.
Thank you, Navas. I think it was very good. I think one point in this was where do you drain. So I think that you already answered because
Yes,
that retinotomy happened, because that is one very important aspect of this. The other thing that I wanted to comment was that with a 30th axial length in these eyes, I would have probably preferred 23 gauge. Not that 25 does do reach, but the important take back message is that sometimes there's a staphyloma over there.
Yes, sir.
Especially at that point where the macular hole is. And when the staphyloma will never be picked up on a B scan, on an axial length scan
Yes,
at times because it's little juxtafoveal something. So I think 23 gauge was the only thing that
Yes,
I
sir.
probably elucidated.
Because of the flexibility of the instruments with 25 gauge.
Yeah.
Yes, sir.
So otherwise I think very well managed and very well done.
Thank you so much.
If it shows the examination and the diagnosis, if it was diagnosed earlier, could we have prevented macular hole?
So usually macular holes, so the causes of macular holes could be due to...
gyrate atrophy,
Sir,
if you would have detected earlier, could we save the vision
Actually no,
with
sir.
arginine therapy?
Actually no, sir. Arginine therapy would not help in that. Arginine therapy would only help in reducing the ornithine levels and further damage. Whatever RP loss and everything that has happened before we initiated that would not be able to be reversed.
I think the cause for the macular hole is more of abnormal vitreoschisis.
Yes,
So
sir.
they have multilayer vitreoschisis
Yes, sir.
in these cases, and that causes the macular
Yes,
hole.
sir. The anterior posterior traction combined with the vitreous.
Digestion. So that really would not.
Earlier, how many cases of gyrate atrophy you have seen?
So we've seen a few at RP center, but
Few.
with
I
macular
believe
hole,
we
I've
were
never
not
seen
able
one.
to diagnose these cases. We were not. This is one of the interesting cases where she was able to diagnose gyrate atrophy and very good presentation. Okay, thank you.
Thank you, sir.
So.
Good morning, one and all. Myself, Dr. Kirbalani Selvan, second year PG resident of Safdarjung Hospital, here to present the case titled The Equal Threat. So, why have we named it so? We'll know it in the following slides. A 17-year-old female presented to the IOPD with complaints of right eye diminution of vision for 3 months, which was gradual, progressive, painless. She gave no history of preceding trauma or surgery in the right eye. However, there was history of sudden onset diminution of vision in the left eye 2 years back. She was shown elsewhere, operated for cataract, and she has poor post-op vision gain since then. Past history, there was no history of ocular trauma or use of spectacles. She underwent uneventful cholecystectomy in the year 2023 for abdominal pain. Her perinatal history was within normal limits. However, her father has low vision in the right eye since 30 years of age. He was not available for examination, nor records were available. On ocular examination, right eye visual acuity was 636 with normal anterior segment, whereas in the left eye she was denying PL with anterior segment showing seclusia pupillae with iris bombay and PCIOL, and there was no view of the posterior segment in the left eye. Posterior segment photo of the right eye shows large elevated orangish vascular lesion with dilated tortuous artery and draining vein in the superior quadrant with multiple small orange lesions arising from retinal vessels with surrounding exudation in the temporal quadrant with peripapillary massive subretinal exudation and hard exudates at the macula. Retrospectively, we asked history of headache, seizures and generalized body weakness, which was all negative. She had no history of hearing difficulties, dysuria or hematuria, and she gave no history of family history of sudden deaths or malignancy. A provisional diagnosis of right eye multiple retinal capillary hemangiomas with macular edema was made and left absolute eye status post cataract surgery. We suspected von Hippel-Lindau disease in this patient as it was an young age at onset. She had a bilateral disease with multiple retinal capillary hemangiomas and unknown cause of vision loss in the father. So we planned OCT macula and FFA of the right eye and USG B scan of the left eye. USG whole abdomen and MRI brain was done to rule out other VHL related tumors, and family screening was also planned. OCT macula of the right eye shows subretinal fluid with hard exudates at the fovea, and FFA of the right eye shows dilated tortuous retinal vessels with hyperfluorescent lesion in the superior quadrant showing leakage. And B scan of the left eye shows disorganized globe structure suggestive of atrophic bulbi. On systemic radiological imaging, it was normal. However, on MRI brain and spine, we found RD with CD with retinal tumors in the left eye, which was an absolute eye. And Puton audiometry was within normal limits and BP monitoring was within normal limits. So we started the patient prophylactically on oral steroids and atorvastatin, followed by right eye intravitreal ranibizumab. So OCT, post which there was resolution of SRF and decrease in exudates and visual acuity improved from 636 to 69. Next step, we planned for laser photocoagulation of the retinal hemangiomas with single spot double frequency NDR laser, with which the smaller lesions were blanched with laser. However, there was poor uptake of laser in the superior quadrant, so a row of spots was created around the lesion to limit the exudation from extending onto the macula, and multiple sittings of laser were planned. We noted recurrence of SRF at 1 month post-injection with fluid extending up to the fovea, and the visual acuity dropped from 6.9 to 6.60. So what do we do next? Clinically, a fibrous band over the large lesion with traction on surrounding retina was noted. So, as there was a poor uptake of laser over the lesion, as well as there was a risk of crunch phenomenon with repeat injection, we decided to refer the patient for a second opinion to RPC AIIMS New Delhi, where she received repeat intravitreal ranibizumab and triamcinolone acetate. On follow-up, we are planning to supplement laser 1 month post-injection with annual monitoring for systemic tumors and gene counseling for VHL mutation, and family screening is also planned. So we conclude by saying that VHL syndrome presents heterogeneously in different patients, with retinal capillary hemangioma as the presenting feature in 50% of the VHL patients. And it is essential for an ophthalmologist to diagnose retinal capillary hemangiomas and refer the patient for systemic screening. Lifetime screening for VHL-related tumors is essential, which can be mitigated by gene testing. Thank you.
I think these tumors are obviously very difficult to manage, and I think with the fibrous element, I think the treatment which was postulated is absolutely right. But then if the traction increases, then surgery is the only inevitable part, but then that they also really don't this thing. One other aspect is cryo, which could be used in these cases. Anyways, I think he's got a long course ahead, and I think it only thing that I would change in this or would think about was that probably do the laser in the other parts first and then go to the angioma, and would not try to hit the angioma directly with laser. I don't think such a large angioma can really go down with a focal laser or anything. Cryo maybe yes, but then again with that fibrous element, it becomes a little tricky. So but I think slow and steady would work in this.
So that's why we just hit the laser. We did not directly hit the tumor. We just placed 2 rows of laser around the hemangioma, so that the exudation doesn't extend to the macula and worsen the visual acuity.
And then there are surgery where they're doing basically, they do ligation and everything, which can also be done. But then given the one eye status, I think I would be very, very cautious in going very aggressive, because ultimately even surgical results don't sometimes prove to be very, very great.
नाम लिखा हिप्पलक्राइट, क्या मतलब है?
So the Hippocrate in our case is non-Hippal window disease. So Hippocrate को
So वो
Hippal
पहले
कहते हैं.
diagnosis बता देती तो फिर.
चलो, thank you.
Thank you.
Good morning everyone, I'm Dr. Fatma Munshi and the title of my presentation is The Best Way to Disguise as the Great Masculine. A 30-year-old female came to ophthalmology OPD with chief complaints of diminution of vision in both eyes since 3 years, which was gradual in onset, progressive and painless in nature. There was no history of similar episodes in the past, no history of spectacle usage, no presentation in sibling, no history of trauma, redness of eye, photophobia, floaters or flashes of light. There was no history of recent surgery or any radiation exposure or anemia. There was no waxing and waning of the visual symptoms. There was no history of tuberculosis or contact TB or any lesions around the eye. No history of drug intake or any other systemic illness. She visited to a different ophthalmologist 10 days back with similar complaints. Her fundus findings recorded were diffuse pigmentary changes with subretinal edema both eyes, which was left more than right. She was advised CBC with ESR, chest X-ray, MON2, ANA, RA factor and serum ACE levels. She was started on ATT after positive MON2 test with a diagnosis of choroiditis both eye. Her personal history was normal with no addiction of smoking or alcohol. The general and systemic examination was normal. Coming to ocular examination, facial symmetry was maintained, head posture was normal. Visual acuity right eye was 612 and left eye was 660 without any improvement. Color vision right eye was 10 by 17 and left eye was also 10 by 17. IOP on Goldman applanation tonometry was 14 and 18 both eye with a normal other ocular examination. Coming to fundus examination, right eye, glow was present on distant direct ophthalmoscopy, media was clear, disc was normal in terms of size, shape, color and margins with a CD ratio of 0.4:1 and RR was healthy. Oval yellow smooth elevated lesion covering the fovea with dilated vessel was present. In the left eye, there was yellow pigmented lesions on and around the fovea resembling scrambled egg appearance with dilated vessels. On the right side, this was the appearance of the fundus. We did an autofluorescence and in the right eye there was oval area of autofluorescence and in the left eye there was peripheral ring of hyperautofluorescence. On OCT macula, there was deposition of homogeneous hyperreflective material in the retinal pigment epithelium and subretinal fluid was present. We did an FA for the patient and there was hypofluorescence secondary to block fluorescence in the area of vitelliform deposits. There was no sign of choroidal neovascular membrane. We did an electrooculogram and the Ardens ratio was 1.2 right eye and 1.3 left eye. My final diagnosis was both eye best vitelliform macular dystrophy, right eye vitelliform stage and left eye vitelliform stage. We stopped the ATT after consultation with infectious disease specialist and we reviewed the patient every 3 months to look for any CNVM changes. Thank you.
So what basis you started ATT?
So the ATT was not started by us. She basically visited someone else and they started it only on the basis of a positive MON2 test.
Okay, positive non-text is not the criteria you should take.
Yes sir, yes sir. That's why we stopped the ATT after.
So clinically you made the diagnosis of?
So clinically, because of the presence in the right eye, there was an elevated oval lesion and the left eye.
Thank you.
Thank you.
So next, call upon Dr. Prachi Sharma.
Hello, good morning. I'm going to present a case of bilateral angle closure glaucoma in acute posterior multifocal placoid pigment epitheliopathy. It's not moving. Yeah. This is a case of 25-year-old female presented with the blurring of vision in both the eyes, right eye more than left eye. BCVA, intraocular pressure, anterior segment, posterior segment and OCT was done. All were in the normal limit. She was asked for a follow-up after 1 week, but then she came again after 3 days with complaint of blurring of vision, both eyes, right eye more than left eye. It was sudden, progressive, associated with moderate to severe headache. No history of any systemic disease. On examination, BCVA, right eye CF 2 meter, left eye 6/12. IOP was normal. Pupillar reaction, right eye sluggish, left eye normal. Color vision, right eye 1/25 plates and left eye normal. Slit lamp examination within normal limit, both eyes, no uveitis. And dilated fundus examination, media clear, no Vitreo cells in both eyes, but multiple grey white placoid, blister-like lesion in both the eyes in the posterior pole, right eye more than left eye. This is the fundus picture. You can see multiple placoid lesion, right eye more than left eye, and the right side is the autofluorescence picture. Then OCT was done, shows right eye, a huge bacillary layer detachment which is known as Ballard, and left eye, the serous detachment of retina is there. And this is the picture of FFA and ICG. Left side denotes the right eye and this is the left eye. All your phase there is total choroidal plus, and in between phase, every phase you can see the hypo, typical of APM-PP, and late stage hyperfluorescence of the FFA. But ICG every stage it is hypofluorescent. But in the left eye there is one phase in ICG you can see there is hyperfluorescence. So this is a dilemma whether it is APM-PP or VKs. Because APM-PP, VKs both relatively same presentation. There is a subtle difference between the two, but during the course of presentation we thought APM-PP because of response to treatment and all, I'll tell later. So all investigation, blood, MRI and brain orbit CT chest to the normal limit. She was diagnosed as a case of APM-PP, can be VKs, and started with high dose methylprednisolone and asked followed by oral prednisolone and asked for follow-up after 7 days. But surprisingly, patient came again after 4 days with complaint of left-sided headache, but vision was improved. BCVA, right eye 6/18, left eye 6/6 partial, IOP 13 right eye, left eye 22. There was shallow AC in both eyes, gonio done, 360-degree angle closed in both eyes. So immediate YACPI was done in both eyes, steroids were continued and advised for a follow-up after 7 days. Patient was doing well after that. This is the picture YACPI done in both eyes. And after 15 days presentation, you can see the central macular thickness fluid grossly reduced, and after 1 month follow-up, 1.5 and 4 month follow-up. Right now also, after 1 year, patient is presenting like this, quite okay. This is the picture of ultrasound D scan at the choroiditis she also had at the time of presentation after 4 months. It is, choroid appears to be normal, no choroidal thickness. So my take-home message is APM-PP or VKS. Glaucoma is very rare complication and rare manifestation. Acute angle closure glaucoma is not a common manifestation, but pathogenesis can be due to acute inflammatory edema or inflammatory cells being close to the trabecular meshwork or damage to the blood aqueous barrier causing ciliary body rotation, then forward movement of iris and lens causing pupillary block. So differential can be this, and this is the reference. Thank you. Yes, sir.
So what was the cause of glaucoma? Was both the eyes shallow antechamber before the?
No. Before it was absolutely normal.
Normal.
It was absolutely AC was reached.
So
normal.
what pathogenesis you were seeing?
That's what inflammation. Inflammation and pushing of the lens side because of the ciliary body swelling and deposit of trabecular. They say trabecular meshwork inflammation, ciliary body swelling, pushing of the lens iris diaphragm forward causing pupillary block.
And treatment-wise, what is difference between AMPP and VKH?
Treatment virtually same, but only thing difference why it is more in favor of APM-PP than VKs. Typical VKs will get starry eye pattern, more sort of hypo and hyperfluorescence, pinpoint, and proximal, and in the long not associated with any cutaneous symptoms like vitiligo, poliosis, which is happening in case of vitiligo, not in APM-PP, and fundus picture and chronicity. VKs won't usually they respond to steroid. But again, recurrence is there. But we are following up for 1 year. There is no recurrence. But patient is still on 5 mg Visolone. We are continuing thinking, she is a young girl, 25. So thinking by chance it will, and she is tolerating well. But absolutely she is stable now.
Only thing I wonder with that thing is that how did the pupillary block happen? Because the patient was already on steroid for very long.
So that is what's surprising.
Yeah,
that is the main
that is the surprising.
My question is, it was already bilateral shallow antechamber with repeated dilatation.
No. We are following her up. We are following her up.
Okay, thank you. Next is Dr. Atika.
Good morning everyone. I'll be talking about a case of bilateral neovascular glaucoma who presented quite late to us. So this was a 20-year-old male who complained of headache and severe diminution of vision in both eyes. And when we took the past history, he gave a history of vague trauma to his head around 3 months back, and for which he consulted a private practitioner. He had the previous documents and which denoted that he has a visual acuity of 618 in his right eye then. And the left eye was noted as PL absent then also. There was an MRI document also, and it showed dilatation of the optic nerve sheath and hypoplasticity of the left transverse and sigmoid sinus. And he was administered low molecular weight heparin and rivaroxaban by the practitioner there. And his personal history was normal. Family history was also normal. The general examination, his vitals were maintained. The systemic examination was normal, like he was well oriented in time, place and person, and everything was normal, all the cranial nerves were normal. In the ocular examination, what we could see was, in the right eye when he presented to us, the PL was doubtful in the right eye, earlier which was 618. And in the left eye, he was PL negative, and the IOPs were raised to the up to 50 mmHg in the right eye and 56 mmHg in the left eye. When we performed a slit lamp examination, everything was normal except that the pupil was dilated and fixed, and we could see neovascularized fronts. In the right eye it was from 6 o'clock to 8 o'clock, and in the left eye it was from 12 o'clock to 2 o'clock. In the lens the cataract was present. In the fundus there was bilateral venous obstruction, the disc margins were blurred, the CV ratio was not appreciable, multiple hemorrhages were there. In the left eye the media was hazy and details was not seen. MRI was done and an NR setup, and it showed a thrombus in the superior sagittal sinus, a flattening of the posterior sclera at the optic disc with prominent bilateral perioptic CSF spaces, and a thrombus was there also in the left transverse sinus. So we suspected that whatever was there was secondary to the insult in the brain. And the patient was advised, because of the high pressures, he was advised the following, and was planned for a 270-degree cyclocryotherapy because he was having pain also. And a tablet estazolamide was advised with a topical anti-glaucoma. Post-cyclocryotherapy, the pressures went down and the patient has a little less pain in his left eye, and the congestion also reduced. So neovascular glaucoma is a sight-threatening secondary glaucoma characterized by appearance of new vessels over iris and proliferation of fibrovascular tissues in the anterior chamber angle. The main etiological factor is retinal ischemia, which leads to impaired hemostatic balance between angiogenic and anti-angiogenic factors. So high concentrations of vasogenic substances such as VEGF induce NVI and NVA that limits the outflow of aqueous humor from the anterior chamber and increases the IOP, which happened in our case. So neovascular glaucoma, if left untreated, which was in the case in our case, it progresses from secondary open angle to angle closure glaucoma, and it leads to irreversible blindness. It is an urgent ophthalmic condition, and early diagnosis and treatment are needed to preserve vision and loss. Unfortunately, the patient presented late to us, so we could not do much but relieve the pain only. So my take-home message is always have a look at the fundus in a head trauma patient, and if possible, take a fundus photograph. It can help and detect and prevent the potentially vision-threatening conditions. The patient is a young male, and unfortunately, we cannot do much about this patient. Thank you.
Thank you. That was
Early identification is one of the important.
The patient presented too late to us, and we wanted to give this message that he is a young patient, he is bilaterally blind, something which could be prevented at that point of time.
Now I ask Dr. Anamika Srivastava is there. Thank you. She will be talking on clinical.
Good morning everyone. My topic is clinical assessment and treatment methods in case of traumatic submacular hemorrhage. A 14-year-old female came with a firecracker injury in her right eye on her second day. She complained of sudden painless loss of vision in her right eye while there was normal vision in the left eye. There is no history of redness or pain in the eye, no other prior history of ocular surgery or trauma is present. Her ocular examination, the vision is hand movement in the right eye while it's 6/6 in the left eye. The other ocular findings are normal. Anterior chamber findings are normal, while in the pupillary reaction, in the right eye there is RAPD grade 3, while there is normal pupillary reflex in the left eye. The IOPs of both the eyes is normal and the lens status is phakic and there is no lenticular opacity. In the dilated fundus examination, In the right eye, there is a dull foveal reflex with a large bright area of around 4 disc diameter, with central 2 disc diameter gray area of RPE changes, along with the presence of there is concentric choroidal tear with tapered and nasal to the macula. Now coming on to the OCT, in the right eye we can see there is a dome-shaped elevation of central retina with loss of foveal contour. The pre-retinal and intraretinal area is normal, while there is a collection we can see in the subretinal area with shadowing. We cannot comment on the RPE status because of the presence of shadowing. Here we can see there is a central macular thickness of 397 micrometers. The approach after the thorough anterior and posterior segment examination, the single dose of intravitreous anti-VEGF ranibizumab was administered on the same day of presentation, and she was put on weekly follow-up. There was no improvement of vision was seen in the second week, and hence she was planned for pneumatic displacement with intravitreous C3F8 gas and was advised lying prone for the 2 days. After 2 weeks, we can see the vision had improved to 2/60. On the 4th week, her vision was 3/60 and she was given another injection of ranibizumab. She came for the follow-up 2 weeks later when her vision came to 5/60, following which there was no further improvement. Here we can see this was the OCT image after 4 weeks when she came up after 1 month of the second injection. There is presence of foveal contour. The pre-retinal and intraretinal level is normal, while there is collection here we can see at the subretinal area, and minimal shadowing is present. Now discussion. Submacular hemorrhage is a catastrophic sequelae of several disease processes and leads to considerable visual impairment. The management options for treating submacular hemorrhage has undergone paradigm shifts over the past decade. Giamberto Cassini et al. Recommended pneumatic displacement with prone position in young patients. The role of anti-VEGF agents is more defined in the patients with associated posterior segment pathologies. Here we can see that anti-VEGF is only performed as an adjuvant treatment. Alone, anti-VEGF had no role. The PPV with subretinal or intraretinal TPA with gas tamponade is the recommended standard treatment. Conclusion. The traumatic submacular hemorrhage has unfavorable evolution and persistence of blood, which causes photoreceptor toxicity, warranting timely intervention. In our case, the initial treatment with anti-VEGF showed no effect. After further gas tamponade, we could see the resolution of hemorrhage with vision improvement. The management options for treating submacular hemorrhage has undergone paradigm shifts. Hence, we can conclude that early and appropriate intervention are the key determinants of the final prognosis. Thank you.
What is the standard management of traumatic submacular hemorrhage?
Sir, according to the literature, sir, the standard management is the past skin vitrectomy. The pneumatic displacement is done along with TPA, subretinal TPA. We did not perform subretinal TPA at our center. But
why subretinal TPA?
So because of the presence of submacular hemorrhage, there is deposition of
subretinally.
So they have seen that when TPA could be given subretinal as well as alone as well. But they have seen, the literature has seen that the subretinal TPA has a better prognosis.
A role of anti-VEGF?
So as in my case as well, so when we gave anti-VEGF before the pneumatic, there was no improvement in the vision. It's only acts as an adjuvant treatment. So the literature is not completely present here as to what should be done about the submacular hemorrhage.
So there is no role of anti-VEGF in submacular unless there is a CNV.
In my case, it's only used as an adjuvant treatment.
See, what is the primary thing that you want to do when you want to attend these cases? What is the primary function that you want to achieve?
So to exactly evaluate how should be.
No, I think the primary thing only in this case is to shift the hemorrhage from the macula. That's the only thing.
Yeah.
Okay, so it can so only just gas or gas with just intravitreal TPA can also do it. If you have a very large hemorrhage with a detachment or something, then you go ahead and do a vitrectomy. But other than that, I think just giving an anti-VEGF in the beginning is really not. I think you also said in your discussion So I think that is really not required. So the primary concern is to save the macula, so you kind of shift the hemorrhage. Yeah, that's the basic thing that you want to do. And then obviously there are further investigations that you can do to see whether you want to intervene again, because there would be ultimately there would be a breakthrough somewhere, and this will come into the vitreous cavity, right? But the primary concern is to shift it from the macula. That's the main thing.
Any other presenter? Thank you. Any other presenter?
Rashmi, where is your talk? But it is not. Is it in the next session?
Number 13, sir.
Number
A case report on successful management of postoperative vitritis. So my patient is a 64 years male, presented to our OPD with chief complaints of diminution of vision of the right eye since the last 2 days. History of present illness. On elaboration, patient underwent an uneventful cataract surgery of the right eye on 7th of March, and on postoperative day 5, he presented to the department with progressive diminution of vision that started since the last 2 days, which was associated with mild pain and watering. There was no history of any fever or any other systemic infections. Patient underwent uneventful cataract surgery of the left eye 4 months back in our hospital. There is no history of any similar illness in the past. Family history, there is no significant family history. Patient is non-diabetic and non-hypertensive and has no known allergies. General examination of the patient were all within normal limits. Systemic examination was again within normal limits. Coming to the ocular examination, on the first day of presentation, that is postoperative day 5, the visual acuity of the right eye of the patient was PL positive and PR was accurate, whereas on the left side was 612. The anterior segment findings of the left eye were all within normal limits. For the right eye, the intraocular pressure, which was measured by non-contact tonometer, was 24 mm mercury. The extraocular movements were full, free and painless. The lids were normal. In the conjunctiva, mild congestion was present. The cornea showed descendant membrane folds with microcystic edema. In the anterior chamber, hypopyon of 2 mm height was noted, and cells and flares of grade 3 was present. The iris details were clear and the pupils were sluggishly reacting. The PCIOL was in bag and retrolental exudates were noted on dilatation. Fundoscopy, very poor fundal glow due to vitreous haze was seen, whereas of the left eye, the media was just mild hazy due to posterior capsular opacity. The rest fundus findings were within normal limits. So this is the straight-line photograph of the patient of the right eye on postoperative day 5, where we can see the corneal haze due to microcystic edema and descendant membrane folds. Hypopyon of 2 mm height can be seen here with PCIOL exudates. On the same day, a USGP scan was done where we can see mild to moderate reflectivity in the anterior hyaloid, anterior vitreous cavity. The hematological investigations, the patient had borderline increased levels of white blood cells. And then the rest of the investigations were all within normal limit. The patient was given injection dexamethasone 2 cc IM, and he was started with prednisolone acetate 1 hourly, hydroxyfloxacin, atropine, and systemic antibiotic tablets of cefuroxime, pentopen, NSAIDs. On the postoperative day 6, vitreous tap was done and sample was sent for culture and sensitivity. Patient was also given his injections ceftazidime and vancomycin intravitreally in the right eye. The gram stain and KOH mount showed no organisms and the culture report showed no growth. So the oral prednisolone was started, and which was continued for 1 month in a tapering dose. So these are the serial postoperative photographs. The first picture showed again microcystic edema on day 6, which was cleared on day 14th. And the last picture showing slit-lamp examination of the anterior segment on the 2nd month. This is a serial photograph of the patient on the end of the 1st month, which showed floating vitreous opacities. So on the last follow-up, on the 3rd month, we can see the patient had improvement in the visual acuity from PL positive to 6.9, which was with minus 0.5 spherical lens and minus 0.8 2.25, cylindrical lens in the excess of 95 degree. Intraocular pressure of both eyes were again normal, and the rest of the anterior segment findings were normal. These are the differential diagnosis. The case summary: the 64-year-old male presented with progressive diminution of vision with pain and watering since postoperative day 5. Injection intravitreal of ceftazidime and vancomycin were given. Vitreous step was done and sent for culture and sensitivity, which showed no organisms or growth. Systemic steroids were started for a duration of 1 month, with which the patient showed dramatic improvement. Thank you.
So it is a case of post-op endophthalmitis or toxic lens?
So now we can say about maybe lens-induced
Endophthalmitis.
So what was your diagnosis? What was
Endophthalmitis, post-op endophthalmitis, or
We
the
thought it to be post-op endophthalmitis, but then on the second day he showed improvement after given oral steroid.
Was the patient seen on day 1 and day 2?
On day 1 he was sent and seen and discharged.
And day 2 he was not seen.
so corneal involvement was on day 1.
My microcystic edema was there.
Was there. That can be due to
It's a prolonged duration of surgery.
any point in favor of toxic lens syndrome. So do you think it is a post-op endophthalmitis? Any role of systemic steroid? You are giving a systemic antibiotic?
So, no sir. Initially we thought endo, so we gave systemic.
What? Okay. Thank you. This is a case of post-op endophthalmitis. Thank you. कहाँ से हैं आप? Assam. Good. Good. ठीक है presentation. Thank you. और कोई anybody would like? क्या भी और किसी ने बोलना है?
Sir, your name?
Dr. Ashwini Kumar from Patna.
I think it is in the next session maybe.
नहीं कोई बोलना क्या?
इसमें नहीं
LR2 में है?
नहीं LR2 में अभी एक और सेशन भी होगा ना.
अच्छा ठीक है.
अच्छा आपका presentation है?
हाँ सर मेरा बता रहे हैं. It's from 12:15.
अच्छा